My name is Adrian Liew. I'm a nephrologist based in Singapore, and my task today is to talk about the development of dialysis programs in low-resource settings. It is unsurprising that there is a growing epidemic of chronic kidney disease as well as kidney failure across the world. In this 2020 Lancet paper published by the Global Burden of Disease Study, they looked at the epidemiology as well as the incidence of chronic kidney disease between the years of 1990 to 2017. And they found that in 2017, 1.2 million people has died from chronic kidney disease globally. And the global all-age mortality rate has actually increased by about 42% between 1990 and 2017. Now, chronic kidney disease also resulted in about 35.8 million disability-adjusted life years in 2017, one-third of which was due to diabetic kidney disease. But what was more concerning was that most of the burden of chronic kidney disease was concentrated in the lowest 3 quintiles of social demographic index. Now, in particular, regions like Oceania, Sub-Saharan Africa, and Latin America, the burden of kidney failure was higher than expected for the level of development in these countries, highlighting the great impact that kidney diseases have in these regions. Moreover, the inability to provide sustained long-term kidney replacement therapy is a big issue in many low and middle-income countries. Now, in this paper by Dr. Gloria from South Africa, she highlighted that about more than 80% of patients had to stop dialysis, even though there were medical indications to do so, and that there were less than 10% of patients who were able to continue dialysis for more than 3 months, and this was a much lower percentage when we looked at the ability to continue dialysis for more than a year. And financial obstacles is the main driving force for the inability to provide long-term life-sustaining dialysis treatment in these regions. And the inequity to access to kidney replacement therapy is actually most felt in low-income as well as lower middle-income countries. Now, in this region, despite the high number of patients with end-stage kidney disease, the actual number of patients who receive dialysis treatment is extremely small. Now, this is in contrast to the high-income countries where the discrepancy is actually very much smaller. And it is because of this inequity to dialysis access that the International Society of Nephrology, as well as the International Federation of Kidney Foundations, decided to focus on the theme of kidney health for everyone and everywhere for World Kidney Day starting from the year 2019, and hoping to raise awareness of developing universal healthcare to kidney conditions and as well as dialysis treatment. At about the same time, the International Society of Nephrology held an ESKD summit in Sharjah at the United Arab Emirates in 2018, with the focus of trying to increase access to integrated ESKD care around the world. The summit brought together key experts and key opinion leaders from various countries and regions to discuss the strategic plan of increasing access to kidney care. And this resulted in a publication in Kidney International in 2019. And the strategic plan that was developed to ensure that people all over the world in different cultures and different healthcare economics and in different resource settings are able to access ESKD care is to consider this in an integrated approach and not just to focus only on dialysis. And this is because dialysis provision is a very expensive endeavor, and that one should also take into account the prevention of chronic kidney disease, which will be a much more cost-effective approach. At the same time, it is also very likely that not everyone will be able to receive dialysis, and therefore a very comprehensive conservative care should be developed in many of these countries, so as to manage patients with ESKD who were either not able to access dialysis treatment or who were not found to be suitable for such therapies. And the other initiative by the ISN was the establishment of a document that basically outlined the framework for the development of dialysis programs in low resource settings. Now, this came as a request from the WHO, where there are member states who have been asking for advice and guidance on developing either new dialysis programs or improving on the existing dialysis programs in low and middle income countries. Now, this document is widely available at our ISN website, and I will be highlighting some of the issues that have been outlined in this document and what are some of the solutions that we can implement in many of these countries. Let's start by just taking an overarching view on what are the principles for developing dialysis programs in a low resource setting. So the way to developing dialysis programs in many countries should adopt the WHO health system approach. Now, this approach takes into consideration several building blocks, which includes governance as well as financing, and to develop health information system and take into consideration the workforce that is needed, as well as the essential diagnostic and technologies are required. And of course, finally, we would also need to review the level of service delivery in providing dialysis. Now, in dialysis planning, these building blocks has various peculiar relevance and consideration, especially in low and middle income countries. And I would like to highlight some of the issues that are peculiar to countries in these regions. The most important starting point in dialysis planning under the governance building block is to do a health technology assessment. And as a case and example, I would like to highlight what we went through in Indonesia, as I was intimately involved in developing the blueprint for dialysis provision in the country for the next 5 to 10 years. Now, the health technology assessment is an exercise in determining the cost of providing dialysis and the ability to sustain this cost over a long period of time. Now, in Indonesia, which is a huge country with which is a large number of islands in the archipelago, there is an important need to decide whether the dialysis program will be that of a HD first policy, or would that be considering PD first policy? And that takes into account several factors, including cost effectiveness, feasibility of providing that dialysis treatment, and what is the 5 years budget impact of providing 100% coverage? Were there any other indirect costs, such as a travel cost by patients? And what is the lifetime cost? And this will then give us an idea that between the two different modality, which is the most cost-effective and the most impactful policy to develop for that particular country. A health technology assessment is a very established way of determining what are the healthcare priorities in a country for a specific condition in a particular group of patient population. There are many factors to consider. These include economic and political factors, which I think is extremely important. It's very important to engage the policymakers and to convince them why a particular treatment modality is cost effective and should be provided to its residents. And of course, there are facilities factors, including those involving the clinician, as well as the infrastructure and education of the healthcare workforce. And these then provide information to policymakers as well as clinician leaders on what will be then the best treatment modality and how then one should go about administering that policy. So a health technology assessment gives us an idea of what is the most cost-effective dialysis modality in that particular country. So for example, in many countries in the world, peritoneal dialysis is considered to be a cheaper option, while that may not be the case in certain regions, like for example, in Africa, hemodialysis appears to be much more cost-effective. Now, once the dialysis modality has been determined, the next step is to really decide on what is the dialysis financing model that the country should adopt. And that model should take into consideration something at the population level as well as the individual level. There are various financial models of example available in the literature. It goes from one that is of a universal health coverage, where dialysis treatment is provided free of charge by the state or the jurisdiction. And there's also the other way in which there is a co-payment model in which patients do have a small amount of out-of-pocket treatment payment for the treatment they receive. Now, which model to adopt should take into consideration the peculiarities of the population as well as the country, including the cultural beliefs, the health-seeking behavior, as well as the available resources. And therefore, underlining the need to personalize the dialysis financing model to the particular population. But regardless of the dialysis financing model that is being adopted, the overarching principle is that the support for dialysis services should be provided in the context of a comprehensive approach to prevention, early detection, and early treatment of kidney disease with a long-term goal of trying to reduce the burden of kidney failure. And that's because once a person reaches kidney failure, end-stage kidney disease, the cost of dialysis provision goes up exponentially. And therefore, for cost effectiveness and cost savings, it is always important to go upstream before kidney failure to ensure that prevention and early treatment is undertaken to reduce this overall financial burden of kidney conditions. And therefore, it is extremely important for clinician leaders in the country to come together to advise the policymakers when determining what is the model of financing dialysis in the country. It is important to ask ourselves or whether there are any societal or political consensus that dialysis should be provided to those who can benefit from it. And if so, how would dialysis be funded sustainably? Now, if dialysis cannot be provided for all, how will access be made equitable? Meaning that the people who are most likely to benefit from dialysis will be given access to treatment, and what are the most efficient methods of dialysis delivery within the limits of available resources? Has there been an assessment of the costs and feasibility that's done to determine which form of dialysis is optimal in the local context? Now, and if dialysis is not provided or chosen, what alternative support, such as that of conservative kidney management, is in place? And the other thing that we have learned from many different countries is that the reliance only on external funding, donors, and charities is really not sustainable. The country, the policymakers have to take dialysis provision into consideration when planning for the healthcare budget to ensure that whatever program that's being developed is going to be sustained in the long run in the country of interest, and that there is no disruption or the inability to continue these programs in the event when charitable funding cease to exist. And these are some of the healthcare financing models that are listed in the ISN WHO document. We highlighted three broad areas. The first is that of domestic revenue generation by the government, and this could be achieved through general taxation or on specific taxes on undesirable products such as tobacco, sugar, or alcohol. And whether there are any efficiency gains, such as reducing fuel subsidies and therefore channeling these revenue to providing for dialysis treatment. The second model will be that through insurance contributions, and insurance could be established through a widespread social insurance, or through the provision of private insurance, or through a public-private partnership. And again, this really takes into account the peculiarities of what is available and what works best in that particular country. There are also alternative sources of funding that are highlighted, such as out-of-pocket payments by the patients, whether there's any community participation, such as voluntary welfare organizations who could run fundraising events to provide dialysis funding. There's also, of course, the development of assistant, charitable, and donor funding that we talked about. And again, I'd like to highlight that this is not sustainable in the long run. And it is not necessary that only one particular model can be implemented in one country. You could have a mix and match of different funding model and different regions of the country. And this is a snapshot from the ISN Global Kidney Health Atlas, which actually demonstrated that in many different regions of the ISN, there are different funding models for kidney replacement therapy, where majority of them use a publicly funded model by the government, and which was free at the point of delivery. But in many other areas, you see a mix of a public and private funding system. So when planning for dialysis provision and financial models, it's always good to decide on what is the percentage of which model that you would like to implement in a particular country. So once a health technology assessment and the dialysis funding model has been decided upon and established, one must always remember that it is almost impossible to ensure that every single patient with end-stage kidney disease will receive dialysis, because it is either because of resource limitations, or the fact that there are some patients who are just not suitable to be placed on dialysis. And putting these patients on dialysis will actually incur cost to the system, and therefore take away funding from people who really need that subsidy. And therefore, it is important in the next step that the jurisdiction needs to make a very ethical decision on what are the dialysis eligibility and which are the patients that should be considered for kidney replacement therapy. And this takes into account several considerations. One is that of clinical. What is the kidney failure diagnosis? What are the comorbidities, the frailty, as well as the projected prognosis? And you do want to give dialysis treatment to people who is going to benefit it most. There are system level considerations, such as the availability of kidney replacement therapy, as well as supportive care. What are the government policies that are in place, or the funding and or reimbursements to not just dialysis, but also to supportive treatment. There are also the patient considerations, and values and cultures are going to differ in different countries, and so that needs to be taken into account. What are some of the lived experience and the life goals of the patients, and whether information is provided adequately to the patients, what is the quality of life, and of course the family resources and values. And then these all needs to be undertaken into a shared decision-making process before deciding on the eligibility of a patient for dialysis. So then the next principle that we want to talk about is the development of health information systems. And that is through the establishment of national or regional registries, really to report outcomes and to audit the dialysis units. And this is a very important process, because you can't have dialysis units springing up across the country, but not knowing whether they are providing the best care and whether the precious dialysis dollars is really put into good use. These could be published on the annual reports to highlight the differences in outcomes in different units. And as well, this gives us the ability to consider linking reimbursements of dialysis treatments to proper reporting. And really, there are many ways in which registries could help to improve the delivery and tracking of kidney replacement therapy. Especially, this gives us an idea of how prepared the unit is and what is the quality of the delivery of care, and as well as the effect of providing such care on both clinical as well as patient-reported outcomes. Then subsequently, when the policy, the funding models, the registry at the high level policymaker is established, the next step is really to go into the nitty-gritty details of how to establish the dialysis treatment modalities in particular units. And in the ISN WHO document, now this is a very busy slide, and I don't intend to go through it in detail, but this document is widely available in the ISN website. And we provided the essential requirements or a checklist on what is required when one prepares to establish a dialysis unit. For example, what is needed for the equipment and supplies, and what is the environment requirements in terms of waste disposal, the workforce that is necessary, the support services, and of course, the clinical guidelines and documents that needs to develop for each of these dialysis modalities. So as I mentioned, these requirements, both general as well as logistic requirements for the dialysis operations are made available as a checklist in the ISN WHO document. So any units who's intending to start up could go through this checklist to ensure that everything is taken into account and that the provision of dialysis is of a high quality. Now, despite all the planning as well as the development of policies, there are bound to be challenges when we try to deliver dialysis for as many people as possible in the long run, especially in the low-income countries. And I would like to highlight some of these challenges that we have learned when trying to start programs in some of these countries. And these are also available in the ISN WHO document. At the same time, we try to provide some solutions to some of these obstacles. Now, one of the biggest challenge is, of course, sustainability, and this could be due to a variety of reasons listed here, such as inadequate infrastructure, the shortage of trained personnel, as well as the lack of regulatory framework for quality assurance, the existence of poor governance, and the limited ability to meet current and future demands. Now, ISN has developed a wide range of collaborative training programs to train healthcare professionals, not just clinicians, but nurses and as well as allied health in the delivery of high quality dialysis. And that is widely available in many, to many low income countries. There is a need for the clinician leaders to come together to try to convince the government as well as the policymakers to commit to progressive expansion of service over time. And it is important to develop and establish a governance and stewardship and transparent framework. And of course, there are quality improvement programs widely available in the literature that could help to establish quality standards. And it doesn't mean that while you're in a low resource setting, that the quality of dialysis will be low. A high quality standard could also still be achieved. And then there are ways in which we could help to define transparent and broadly acceptable patient eligibility criteria that takes into account both the local values as well as preferences. And the lack of sustained dialysis funding is always a key challenge in many low-resource countries. And this may be due to a lot of reasons. For example, there's no consistent policy to fund kidney replacement therapy, or when the development of dialysis services are unplanned, especially in the private sector. And the high out-of-pocket spending often leads to poor outcomes, with many patients and care providers trying to cut costs by avoiding some of the essential treatment that's required for the delivery of high-quality dialysis. In certain countries, for example, in Africa, there's a high cost of PD supplies, and this notwithstanding that we are talking about dialysis, but if there's a neglect for funding for transplant services, or even for that matter, conservative care, then you will be increasing dialysis costing in the long run, because the cost of dialysis provision is still significantly higher than that for transplant, as well as supportive services in the long run. How can we overcome all these? Definitely, WHO has a universal healthcare coverage principles that is listed in their documents, and these are things that should be reviewed when planning for dialysis. As I mentioned earlier, priority setting as well as a health technology assessment to inform the service planning is important. There are certain countries that take into account the ability to incentivize cost-effective kidney replacement therapy options and to remove perverse incentives. The local production of PD supplies, when possible, or the use of regional collaboration may actually make the provision of peritoneal dialysis much cheaper. This has been undertaken in several countries, such as Thailand, where they went into a PD first policy. And really is to try to consider covering the cost of all elements of care of patients with kidney failure, so as to reduce the high out-of-pocket spending for patients. And following on that, there are many ways in which we could increase the financial efficiency in dialysis provisions. And these are some of the ways that we've highlighted in the ICE and WHO document, such as having a central negotiated strategic purchasing, and trying to change professional behavior like task sharing and shifting, so as to make the cost of the healthcare workforce more efficient. And of course, there are many ways in which to achieve operational efficiency, and these are highlighted in detail in the document. And in the interest of time, I will not go through each individual line item. And finally, what I cannot stress any further is that the standards of dialysis provision should not be compromised, despite this is being done in a low resource setting. And that protocols which are widely available in the literature should be developed for various aspects of care in dialysis provision, because in fact, some of these are very simple things that can be done to increase the quality of dialysis provision and to improve the outcomes of patients. And they come at relatively low cost, and but it's often neglected and often forgotten. And so these are highlighted here and readily available in the ICE and WHO document. So in summary, the global burden of chronic kidney disease and kidney failure is high, with a significant impact in low-income countries. Now, the inequity of access to kidney replacement therapies in this low resource setting is a major obstacle to achieving the WHO Sustainable Development Goal of universal health coverage. Now, development of dialysis programs in low and middle income countries should be considered in parallel with the aim of increasing access to an integrated ESKD care framework. A proper healthcare technology assessment and determination of the appropriate financing model are important factors to ensuring the sustainability of dialysis care provision. And that one should develop an eligibility patient criteria for dialysis in an ethical fashion, with consideration of local culture and resources. This should be supplemented by a robust supportive care framework. Now, the ICE and the WHO has developed a toolkit for developing dialysis programs, and this can be personalized to the local setting. And with that, I thank you for your kind attention.